Welcome, everyone. Thanks for having lunch with us. Today we have a packed agenda on a very interesting topic, and it's really related to sort of some new information, new treatments, new process in terms of managing HIV infections, and specifically the data surrounding the state of Washington. So I'm going to welcome you. This is a joint presentation sponsored by the Washington Health Alliance as well as the State Department of Health. And we've got a group of speakers with us. Can you go to the next slide? Maybe 2 slides. Couple of housekeeping topics. You'll notice that you're all muted. However, we will have a Q&A session toward the end. So after our panel discussion, if you raise your hand, we'll unmute you and allow you to come on video and ask your question. You can also put a question into the chat, and we'll get to those toward the end of the presentation. Everyone who's registered, well over 125 of you, will receive slides and a recording of the session. The next slide, we'll just get to our agenda. So it's pretty packed. We're going to have Dr. Yao from the HCA providing us some numbers in terms of HIV in Washington and what those numbers are telling us. Elizabeth Harry will talk a little bit about how do we start closing some of those gaps, and then we'll get some solutions from providers in terms of how we best can lead the way in terms of really suppressing HIV, and in fact are there the possibility of really getting those viral numbers down to close to 0. The next slide, just a little bit about the Washington Health Alliance. We're entering our 20th year, and you'll see that on the right side, we talk a lot about public reporting, and today we're really trying to convene people together to talk about how do we create value for the market. And part of that panel discussion is really how do we make sure that the market actually changes and adapts to information that's out there to really improve the lives of folks in Washington. And then the next slide is really, if you're not a member of the Alliance, we'd love you to become one, but at a minimum, we'd like you to be connected. So please go to our site, get on our mailing list. You'll get information about events like today. Many of you I know are already members, so that's fantastic, but also you may want to engage in some of the committees and the committee work that we do as well. And with that, I'm going to move us forward to our first speaker, Dr. Yao, and I'm going to hand it over to you.
Great. Thank you very much for inviting me to be here today. Let's see, are you running the slides or? Okay,
just
great.
Go forward, yep.
Yes. So I will talk about the data that we've been collecting in Washington State and what might those numbers mean today. So let's go to the next slide. So before I dive into the data, I would like to acknowledge our executive sponsors, clinical leaders, as well as project leads that have supported the work that we've been doing to collect the data for HIV suppression. Next slide, please. So Washington has a relatively low prevalence of HIV. We have about 14,000 people living with HIV in our state, but we continue to see high transmission rates in some of the urban centers like Seattle, Spokane, or Vancouver. Overall, Medicaid carries about 40% of the HIV population, and based on our match with Department of Health, we've come up with a number of about 5,000 clients that are currently enrolled in Medicaid. So HIV is a very high cost disease to treat. The average cost to treat a person with HIV per lifetime can range anywhere between $420,000 to over $1 million. This amounts to a total lifetime cost of 2 to 6 billion in burden to Medicaid, and which represents huge public health and healthcare investment. This brings us to our next topic, which is next slide. So to kind of address this issue, HCA or Healthcare Authority and DOH are participating in a nationwide project known as the Building Capacity to Improve HIV Suppression in Medicaid. This is a multi-state collaborative where we have developed a specific clinical measure or a measure that can be applied to improve clinical outcomes of clients for HIV suppression. And the collaborative started with 8 states in 2020, and in the span of 4 years, we've been able to engage additional states to participate in the collaborative. Right now, we have about 25 states that are ready to report the measure possibly in 2024. And one of the goals of this collaborative is to learn from each other, from strategies that are each other on strategies to improve HIV suppression, as well as generating tools that would help each other in terms of gathering the data to report the measure, which would then help us enhance our national surveillance on HIV suppression. Okay, next slide, please. So just a little bit about what this measure is and what we're measuring. So this is a fairly simple measure that CMS has developed, which includes monitoring clients that are 18 or older, and they must have a HIV diagnosis in the early part of the year prior to our measuring year, as well as requiring the clients to have at least one medical visit, which means that these clients are engaged in care, and that it gives the providers an opportunity to intervene if needed. So, and again, the HIV suppression, we're measuring the percent of people with diagnosis of HIV who have less than 200 copies of HIV per milliliter of blood. So next slide, please. So here's some data that we've been collected between 2020 and 2023. And you can see that our overall HIV suppression has stayed pretty stable in the last 4 years where we're monitoring this measure, with the population that are 65 and above generally performing better in terms of HIV suppression, and the population that's 64 and under having a slightly lower suppression rate than the overall measure. Next slide, please. We also broke out the same population by race and ethnicity. So what we can see here is that no one group has reached the 95% target in terms of HIV suppression. Some groups are doing slightly better than others, but you can see that there are particular race and ethnicity that's currently under the state average, which is 83% for last year's measurement. Next slide, please. And we also looked at the suppression rate in the different Washington populations. So this is the data from the last 4 years, comparing between statewide average versus the King County, where most of our population of HIV resides. You can see from this comparison that overall in the last 4 years that King County has a slightly higher HIV suppression rate compared to the statewide average. And I think, the implication of this is that perhaps King County may have more access to HIV resources based on the Ryan White programs, and or a much more urban area, which suggests that perhaps in rural areas there may be additional barriers that we may need to address to improve the HIV suppression rate in our state. Next slide, please. We also went in and looked at, where the gaps may exist and what opportunities that we may have to improve HIV suppression rate. So in the monitoring cohort that we have in the Medicaid population, for example, of all the clients that did have a medical visit, we know that at least 92% of them had at least one viral load testing done in the year 2023. And at least 78% of these clients had their medications filled with Medicaid. This is likely a underestimate because we didn't include the clients that use the ADAP program to get their prescription. So I think the actual number, it's higher. What we did was to add on another additional analysis, which was to look at, the overall percent, the suppression rate of people the overall suppression rate of people in this cohort versus specifically those clients that had a prescription fill before they had their viral load testing. So these are clients we know that are not only in care, but they've had their prescription fill and then followed by testing. And the suppression rate in that subset of cohort actually is as high as 90%, which is very encouraging, meaning that if we are able to get clients in care, make sure that they stay on their medication, we do have a very good chance of reaching a very high suppression rate in our state. Next slide, please. We also looked at some of the other social determinants of health issues to see whether they can impact HIV suppression rate. So one of the comparisons that we did was to see if clients that are enrolled in Ryan White, what their suppression it's like versus clients that are not enrolled in Ryan White program. And you can see that there is a difference between those who are enrolled in Ryan White versus those who are not, with the Ryan White group having a higher suppression rate. In addition to that, we also look at housing status. So we went into our data set and asked a question, of all the clients that we're monitoring, how many of them do not have stable housing as defined by at least one instance of reporting homelessness throughout the 12 months monitoring period. And we've identified about 500 individuals that we can find in our data set. And when we compare the viral suppression rate, again, those with unstable housing tend to have a lower suppression rate. And if anything, I think this 500 number, it's a complete underestimate of the situation that we're in terms of unstable housing. So which means these factors can also help us drive the suppression rate higher if that can be addressed. Next slide, please. So overall, I think our data have suggest and also confirm what we've already known. If clients can start their ARV interventions earlier, they have a better chance of having better health outcome. If they are on medication, they have HIV load that's being suppressed. That would also prevent further transmission of the virus, as well as being continuously under continuous care and monitoring. And I think being able to do all of these can help clients stay healthy, families stay together, and prevent further horizontal as well as vertical transmission of the virus. Next slide, please. So here's the expectation we have, right? Because I think Washington has a quite relatively high viral suppression rate, and we could probably do better with that. But the expectation is if we have a high enough viral suppression rate, we should start seeing a decrease in new infections. And next slide, please. But if we look back in the last 6 years, what we see here is that the suppression of the new diagnosis trend here, where I have shown the statewide and Medicaid prevalence, it's pretty stable for the last 6 years. And so the question is, what could that mean? Why do we have a relatively high suppression rate, but not seeing a drop or a significant drop in new infections? Next slide, please. We kind of dig into that a little bit to segregate it maybe by race and ethnicity to see if, maybe they're shifting populations. And you can see that in this graph that certain populations have a higher percentage of new diagnosis, and that there are slight changes within the different race and ethnicity groups between 2018 and 2023 in terms of the number of new diagnoses. But overall, the trend stays pretty similar for those years that we have looked at. So next slide. And so in summary, I think what the data tells us that if clients are engaged in care, that can have a much better impact on the suppression rate. In addition to that, many social factors can influence the treatment success. And I think because we don't see a drop in new infection, this calls for like new innovations or collaborations to strengthen these prevention strategies, such as expanding PrEP, testing, and other creative ways to bring the infections down. And I believe that's all I have. Next slide. So I think we can save the question for later. These are some of the questions that I thought we might kind of keep that in our minds as we go through the presentations, and can discuss that in the panel discussion.
Thank you.
Right, thank you.
Pat?
Great, thank you. Thank you to the Alliance for the invitation and for highlighting some of this work. And certainly thank you to Karen and the amazing team at Healthcare Authority and their collaborative work on this. I'm Beth Krutzinger-Perry. I'm the Director for the Office of Infectious Disease at the Washington State Department of Health, and I'm excited to be here today. We can go to the next slide. So I'm going to just cover a few topics. I'll show some different slides and different graphs and charts, but I am going to try to move through them rather quickly because they're really kind of just food for thought. I will say some of the information I'm going to give you is kind of new and hasn't actually been fully explored even in my office, but it felt really important for us to be able to share it with this group, knowing that those of you, you are seeing some of these patients in many instances much more frequently or for the first time rather than us. And so I wanted to share what we have. We're going to go through a little bit about the Office of Infectious Disease, not take much time on that. I'll show a slide similar to what Karen has on the care continuum. We'll talk a bit about some trend data around linkage to care and viral suppression, and then a bit about what we know and what we think we might be able to do with what we know. Let's go to the next slide. So this is really just a list of what we do in the Office of Infectious Disease, just by topics. Overarching, we do a significant amount of work around HIV, STIs, hepatitis B and C, and I apologize, I left B off. Oh no, I got it. There we go. Mpox, and we have a substantial program around drug user health, which includes our syringe service programs, naloxone distribution, overdose education, and overdose prevention. Let's go to the next slide. Some of our priorities always are to prevent new infections across our syndemics, across all of the conditions that we work on and with communities around, improve health outcomes, reduce disparities and inequities, which are constant and remain often unchallenged, achieve integrated coordinated efforts, apparently learn how to spell achieve, sorry about that, improve surveillance and data usage, identify and apply, evaluate syndemic-led efforts. We do try to look at our conditions collectively because they often impact the same populations or the same communities. And so we try to talk, work, and fund around all of those conditions simultaneously when possible. Let's go to the next slide. Okay, here's a care continuum. This is a great visual that I love, and it's really, for me, is simple and easy to understand, but I'm not sure if it's the case for everyone. But basically, it walks you through the expectations of an HIV care continuum from diagnosis to viral suppression, and is a metric that's used across the country as it relates to programs like ours, and I'm sure some of yours, for those who know their status. We always have to estimate the number of HIV positive people in the state, even though we don't know for sure those who haven't been screened yet. So the first bar is always an estimate. The second bar is those who are diagnosed, where we have lab results or positive test results on those individuals in our surveillance data. We track then when they're linked into care, when they remain engaged in care, and these are HRSA definitions, the Ryan White program definitions that we follow around what is engagement in care and what is linked to care, and then viral suppression. Our state does amazingly well compared to many. However, we have, as Karen has already indicated, stayed rather stagnant. We have significant investments in resources, and yet we continue to not see the reductions in new infections or the increase in viral suppression that I think we had hoped to see when I took this position in 2018. Let's go to the next slide. Here's just another trend in linkage to care. We do have a mandate and obligation to link new HIV cases that we identify or that we are notified about into treatment and care within 30 days. Ideally, that would be a much shorter timeline. But the goal for this is really around 95%, right? The feds kind of put a 95% on there. We have never met that goal. It continues to be an aspirational goal. And you can see that as time has passed, we have lost a little bit of ground. So this is a trend that shows you our efforts, but we have not met the goals around this and continue to strive. There are, I'm sure, a lot of reasons why we have not met this goal, but I wanted to call it out for you. Next slide. Here's trends in virologic suppression over time with prevalent cases, 2014 to 2023. These numbers are slightly different than what Karen showed you, but still very close. As you know, we typically are just looking at a snapshot in time with all of this data, and it's constantly changing. But you can see that, you know, we reached our peak in 2019. Obviously, 2020 and 2021 are the pandemic years, and things got weird in all data collection during that time and in care and treatment for all conditions and healthcare related issues. And then you see that we are standing at the end of the closeout of the data of 23, we're standing at about 79%. I don't have final data on 24 yet. That really doesn't get finalized and cleaned up to epidemiological standards until the summer. So we will update this chart and all of our charts with 2024 data when we have that. But this gives you a sense of things from as it ended 2023. Let's go to the next slide. Okay, one of the things that we've talked about, and if you remember the bar, is who's out of care. So who's not represented, who's not engaged in care and staying in care. And we have really tried to focus on a deeper dive on who are those individuals and what do we know about them in order to perhaps revise and change our interventions and our efforts. And this is kind of some of the new information that we have. So what I'm sharing today is prevalent HIV cases at the end of 23 from our surveillance data. The N here is the percent not engaged in care is about 1,900. The percent virally unsuppressed is about 3,200. And you can see from this chart that 40% of those not virally suppressed are non-binary or other gender diverse individuals in their gender identity, and then 30% of those not in care have that same those same characteristics. So clearly, this is an indication of a population and a community in need, and our services, regardless of who we are here at DOH in the systems of healthcare, aren't meeting the needs of getting those individuals effectively into care and virally suppressed. Secondly, you see people who inject drugs as their mode of exposure. So they became, they've identified that as how they became HIV positive. 32% of those individuals are not virally suppressed and 17% not in care. Next, US born Blacks at 27% and 14%. And then people diagnosed with HIV between the ages of 13 and 45. So we are seeing an increase in younger individuals who are not, the system is simply not meeting their needs, not showing up in places where they show up so that they can get this care and stay engaged. Let's go to the next slide. And I'm sorry, I am seeing a lot of questions in the chat. I think we're going to hold those, but I will hopefully be able to answer or get back to you with questions. So again, another slide, who is virally unsuppressed in Washington? A little deeper dive. This is a smaller group of individuals, only 94 of these individuals. It's a subsample of our HIV cases, and it is a part of the medical monitoring project, which has been a long-term research project that we have been funded to do at Washington State and in King County as a part of CDC. And this data, while a small number of individuals, because of its trajectory and historical reference, provides us really important information about services, care, and outcomes for people. So they used the MMP data and looked at some of the what individuals reported who were virally unsuppressed as being some of their characteristics. And so those are gathered for you here. It's just another data set that would inform interventions, changes to the system, or alterations that we could make to try to meet people in a more meaningful way and engage them in care consistently over time and help them achieve viral suppression if that is their desire. I won't go over all of this. You'll have these slides, but I wanted to share this data. Let's go to the next slide. Okay, this one I'm giving you as a reference. So living cases and prevalence rates by county in Washington State. You can see the picture here and show the distribution across our state and counties of where cases live. We have individuals living with HIV in every county in Washington State, but obviously larger bunches of those individuals happen in particular parts of the state. And then you can see the prevalence rates by the colors indicated in our chart. Let's go to the next slide. So this one, this is a new slide for me, and it's one of those slides where you're really glad to see it, and I want to say kind of excited, but you are not excited about what you see. But having this information and being able to dig into it this deeply is really important for how we would work with partners and craft interventions in our programs and in our partnerships with all of you. This slide gives you the percent of persons living with HIV who are virally unsuppressed by county. And again, 2023 data. The chart is indicated with, high concern for these bright red jurisdictions. And you can see which of those are here and the percent of viral lack of suppression for people living with HIV in those jurisdictions. So this is new information that we are working through right now, trying to, instead of looking at the bars that are above the line, looking at what is beneath the line in the bars, who's not engaged, who doesn't know their status, and who is not virally suppressed, and what can we change in order to meet some of those needs and give them opportunities that we have not apparently been giving. Let's go to the next slide. So one of the things I wanted to talk about is opportunities, gaps and opportunities. So this is a slide that is also relatively new. As I told you, we work a lot we work with STIs as well. And there are clear correlations between syphilis diagnosis and future HIV diagnosis. So we watch those things very carefully, obviously for the syphilis, because we want to treat syphilis, but also for the bellwether that is often for HIV. But you'll see here, this is data that the surveillance team pulled together around missed opportunities, and noting that there were individuals showing up in emergency rooms across the state in different counties who came in and were screened and treated for gonorrhea and chlamydia or chlamydia, but were not screened for HIV and syphilis, and were at the time had a syphilis diagnosis. And so the syphilis was missed in that visit, and eventually was found and was treated. But the time that happened between that misdiagnosis or that lack of a diagnosis and the ultimate diagnosis and treatment created more partners, more spread, more poor health outcomes for that individual. So this is information that we're going to try and work with our partners, some of you here and others, to try to see how can we assist in the field or in the ER or in clinical sites around making sure that everyone who comes in and is treated or screened for gonorrhea and chlamydia should also be screened for syphilis and HIV. In order to avoid some of those misdiagnoses and continued infections across the state. Our syphilis, I'm not giving you syphilis data, that's a whole different presentation that someone else would need to provide for you, but our syphilis numbers are astronomical right now. Okay, so this is one opportunity that I wanted to propose and data that we have found, and we would love an opportunity to work more on this. Let's go to the next slide. Some other opportunities, and because I said I would keep it short, and I haven't done that. So we have a lot going on in Office of Infectious Disease, and so I have tried to offer some opportunities here and to share with you some of the services and programs that we provide that I think many of you are already partnering with, but if not, we want to make sure we're giving you an opportunity to partner with us and to learn about what we're doing and to increase access to your communities as well as those who may be coming as referrals from us. So this is a short list of our recommendations and our opportunities that we see could exist between our partnership, and I hope you'll take some time to look at that. I don't want to go over it because I want to give time to the other presenters. And I think that may be my last slide. Great, thank you. I look forward to more questions and conversation.
Pass it over to Letitia.
Hi, thanks for inviting me. My name is Letitia McCauley. I'm an advanced practice provider at Chas Health. I've been here, I hate to say this, but since 2003, just means I'm old. And I've been doing HIV care at Chas, I think since about 2008, maybe a little bit before that. I have no disclosures. Next slide, please. So Chas Health is a FQHC. It started in 1994. And I think our first clinic opened in 1995 in downtown Spokane. We've expanded exponentially since then. Now we have about 25 locations and about 1,800 employees, serve roughly 110,000 patients a year. I think that's more in the last couple of years. But we have medical, dental, pharmacy, behavioral health, so full scope of care, and expanding all the time. Next slide. So our HIV team started in 2005. It started with just one MD and I think an RN and a social worker. It's expanded over the years. We now have 2 providers, one MD and then myself. We have an RN, 2 clinical pharmacists, both of which are part-time, a dietitian that's part-time, put RN on there twice, sorry, a licensed mental health counselor, a care coordinator, and then various medical assistants that sort of help us out. Next slide. We have some community partners as well with Spokane Regional Health, SAN, and then North Idaho Alliance for Care. Referrals come from all of those entities, but also from our urgent cares, our primary care providers, and hospitals, and then just other area community partners. Next slide. Our HIV team does not practice in all of our clinics, however. We currently see patients out of 4 clinics here in downtown Spokane, the Valley, and then we also travel down to Lewiston, Idaho, Moscow, Idaho, and then we do offer some telehealth. Next slide. For our team, we do the HIV care, but also the primary care. We have behavioral health, and then we have also substance abuse treatment. Next slide. Our approach to care is sort of a team-based model, and you can sort of probably guess that from all the folks on our team. So visits are designed to allow all of our patients to have access to any one of those team members at each visit or independently as needed. So our visits can be kind of lengthy, as you might imagine, but if somebody comes in and identifies that they need to see behavioral health that day, that person is available to then see them that day without having to come back. Same with the pharmacist and dietitian. We also have independent visits with all of our team members that allows patients to sort of get extra care if they need it, say for adherence, behavioral health, just as whatever is identified for each patient. We also do some community outreach. This is what we've identified as probably one of our biggest areas of improvement over the last year, is we have the RN and the behavioral health provider going out and finding folks in the community and just kind of meeting them where they are. That is expanded into allowing a telehealth visit with that patient at that time. We're hopeful to start sending a provider out, but we haven't been able to do that quite yet. And they do this once a week, and they just tag team and they head out they see people in their homes, they see people in the street. And it's been probably one of the most well-received things we've done recently with our team. We have, Chaz itself has a street med team and a mobile med team. We haven't collaborated them with all that much, but we did steal our RN from that team. But we're hoping to sort of see if we can't work with them a little bit more in the future. Next slide. This is just a little bit about our population. We have about 524 patients that we're currently managing. Just a little demographics about that population. And as you can tell, we're not like anybody else in the state. We have, unhoused population. We have a fair number that are using substances and struggle with mental health. And so not probably much different than what everybody else is seeing in their patient panels. Next slide. This is kind of just a little bit of how we're doing. And this hasn't changed in the last couple of years. Our CD4 rates are pretty average, probably with the state. I think our viral suppression is doing okay. We have about almost 71% that are completely undetectable, and then another 21% that are less than that 200 viral loads. So just over 90%, I think we're doing okay there. And I think if anecdotally, we can all probably think back to our panels, and I've had the same patients in that non-suppressed group for years. And so just trying to figure out how to move those folks into getting that suppression is probably the biggest hurdle we all face. But we're working on that. I'm not sure if I had any more slides. Next slide. Yeah, I don't have any more slides. So that's what I have. Thank you.
Great, thanks for that information, and we'll just jump to Dr. Tung from Kelley-Ross Pharmacy, a sort of different solution that's been put in place, to help. So, Dr. Tung.
Yeah, hi everyone. Thank you so much for having me. So I am a pharmacist at Kelley-Ross Pharmacy, and 10 years ago, we started the first pharmacy and pharmacist managed PrEP clinic in Washington State and also pretty much in the nation. And I'm just kind of here to talk about our experiences and what the model kind of looks like as an alternative way to get people the prevention they need. Next slide. These are my disclosures. Next slide. All right, so just a little bit about the framework of our pharmacy model. First and foremost, it's pharmacists that's providing PrEP care. The pharmacists do all the screening, counseling, prescribing, and all the laboratory work. We do all the patient interviewing and do all the lab ordering and collection of all the samples as well. And we do a majority of our patients do get same day PrEP starts too. We offer all the different PrEP products. 10 years ago, we started just doing oral Truvada, and then Descovy got added on, and now we do a lot of Apretude, long-acting injectable, and we hope to also do the newest long-acting injectable as soon as it gets approved in June. This is all done under a collaborative practice drug therapy agreement, and this is basically a protocol that's signed off by the pharmacist and a physician who's been authorized to prescribe in the state of Washington. It does not need to be a physician. It can be any authorized healthcare provider to prescribe. So it can be ARNP. Ours happens to be a physician, and it is Dr. Peter Shallett of the Seattle area. And lots of states have lots of different rules around their CDTAs. Sometimes it's also known as Cloud Practice Agreements, or CPAs. This is a great link from the CDC that kind of gives you some framework around these kinds of agreements and protocols. Let's see, dispensing of medication once the pharmacist deems that it's appropriate for the person to be on PrEP and they've kind of gone through which one they'd like to choose. We do all the dispensing here in the pharmacy, so patients are able to leave same day with meds. And then paying for the services. Our pharmacists are credentialed and we have provider status. And that was critical to make this a sustainable model. And we're very lucky in Washington State that in 2016, we passed some legislation that forces insurance providers to recognize pharmacists as providers. And so we get reimbursed for all of our services, labs, E&M codes, CPT codes, the same way other healthcare providers do in the state. We always use a person's primary insurance first. We have some processes in place to help people get on insurance if they don't have insurance. And then lastly, there is patient assistance programs. We use both the state PrEP program as well as manufacturer drug assistance programs as well to act as secondary coverage if the person has any copays left over. Next slide. All right, what does a visit look like with our pharmacists? 10 years ago when I started this, it was just me doing this service in between normal workflow in the main pharmacy. So main pharmacy, I would have a patient walk in and say, I want to get on PrEP. I'd step out into the counseling room for a little bit, conduct their appointment, then step back into the main pharmacy and check a bunch of prescriptions and continue normal workflow. So it was definitely juggling multiple hats at once. But the service kind of flourished and took off. And now we have 9 full-time pharmacists on the service. And what the appointments look like is that first, the patients usually find us. We've done a lot of outreach to community-based organizations, a lot of word of mouth, and a lot of advertising to have patients know that we're here for PrEP. They seek us out, they either walk in or make an appointment with us. The pharmacist does the appointment. We do all the sexual history taking, ordering, all the labs, document everything in the EHR, and then when it is appropriate for them to start PrEP, we send a prescription to to the staff who are inside the pharmacy, and they begin getting it ready, filling it and processing it and getting it labeled and prepared. And the technician does that. The pharmacist does a final check, and the ancillary staff gets them checked out at the end of their appointment. Next slide. So I mentioned patient engagement. It's quite robust, and that's a lot of groundwork needs to be done there in order for patients to know that you are there to help them. So as I mentioned, a lot of collaboration with community-based organizations. In the early years, it was a lot of, doing a lot of in-services at a lot of different places, and meeting with community members. We also did a lot of outreach with other healthcare providers and primary care providers to say, hey, if you have a patient that needs to be on PrEP, we can help you out. We can do your PrEP appointment, get them all set up. You can still maintain being their primary care provider. And in fact, we want that to happen. Patients need to have primary care providers, but we can do this for your group. Comprehensive marketing campaign that includes traditional and multimedia digital marketing plans, and also through pharmacy screening. When a patient comes in, they're looking for pregnancy tests, lube, or condoms, or they're picking up antibiotics for an STI. Pharmacists use their training and counseling skills, and drops a question. Hey, what are you doing to prevent yourself from getting HIV? And that usually starts the question and the path down PrEP. Next slide. All right, so there are some benefits of the pharmacy model. Pharmacies are accessible. There are over 60,000 locations nationwide, and 90% of people live within 5 miles of a pharmacy. So it's a great community healthcare place where people can get PrEP, and it's not as intimidating as a traditional healthcare system. We do a lot of walk-ins, and so it decreases kind of that barrier to care. In addition to low barrier care, we take care of a lot of the billing for people, a lot of the patient assistance, the coordination of medication and some benefits. And so because we manage pretty much everything on the PrEP side, top to bottom for people, it's led to improved retention and persistence on PrEP. We have lots of patients who've been in our service for almost 10 years with us. In our protocol, we tell people that they should have a PCP within a year starting our service. Most of our patients don't have PCPs. And so we need somebody to take care of all the other things in primary care: blood pressure, cholesterol, mental health, a lot of other things. And so we're able to link a lot of people up to care. Most of the patients that we have aren't already established in a healthcare system already. Other STIs, we test for all the STIs. We do a lot of immunizations. We do a lot of NPEP as well, too. Through this service, we've expanded to also include hepatitis C treatment and gender-affirming care as well. The population, we have almost 2,000 active patients currently in our service. Over the past 10 years, we have initiated over 5,000 people on PrEP. Majority of our patient population are the 25 to 35 year age range, and so young adults. We have a very gender diverse population, and we have a really strong relationship with the Seattle LGBTQ Center, and we also have a very economically diverse population. We have a lot of patients who have tremendous insurance on great corporate employer provided insurance. And then we also have a lot of people who are uninsured, and we have a lot of people who are students and need a lot of help navigating the healthcare system. Next slide. And that's it on the pharmacy side.
Wow. Thanks to all the speakers. I'll ask you all to come back on, and we have a few minutes, and we'll try to get to some of the questions that are in the chat. If we don't get to all of them, we'll respond to everyone who registered in writing if we don't get to those, and maybe we'll try to put all that together into a brief. But thank you all for your presentations today. I think I'm taken by some of the great work that's been done, some of the solutions that are in place, which are I think really targeting some of the at-risk groups that we saw. I think the other thing that I'm struck with, and maybe it was Beth in your discussion, sort of a stagnation a bit, right? And I'm wondering what some of those, what you're seeing as the big barriers that are getting in the way of that. Is it a behavioral health issue? Is it something, structurally? I think there's concern certainly in rural areas that may be a problem. Although your map showed, some great results in a couple of rural counties. Mason, Kittitas, and Whatcom seem to be the, your best practices. Maybe you could expand on, what's maybe causing some of that stagnation, and maybe what some of the best practices are that we're seeing in some of those other areas.
Yeah, I mean, it's a hard question to answer. I feel like some of the things you've already mentioned, certainly the rural communities do not have the resources. I think stigma is a significant issue in even our urban areas. I think we traditionally continue to see disparities for Black, Latino, Latinx populations, American Indian, Native Americans. These folks continue to be experiencing diverse disparities, and we have not seen that change. Even though we know it and we document it and we make efforts toward it, we have not been able to effectively meet the needs of those communities in a way that brings them into care statewide. I think so I think stigma plays a big part. I think lack of education, continued lack of education, lack of testing, people not understanding, even though we have, mandates for universal testing. I think that's part of it. And then I think it's also a comorbid issue. HIV is not the only issue. It's oftentimes not the most even important thing that a person is dealing with. They are working with substance use issues or homelessness issues, mental health problems, financial poverty issues, housing. So if those don't get addressed, the healthcare needs are never going to get addressed.
I think some of the issues in the rural communities, let's assume they have internet access or phone access, is you can do some telemedicine. I don't know, Elise, if you or even Letitia, you move to more of a telemedicine type model to be able to reach some of those areas, especially if we start seeing more pharmacy deserts occur as pharmacies start to close. What do we think about that?
I think telemedicine is great. It's a great option. We started our telemedicine service very, very serendipitously right before, I think the month before the shelter in place happened in 2020. It was not planned that way, but it just happened to be very timely. And when the shelter in place went, we moved 100% of our patients over to telemedicine in March of 2020. So pharmacies are excellent. We have patients across the whole state because of our telemedicine service. But if there is a pharmacy in Eastern Washington that is a little closer to the patient than we are, then that's even better. But what's also nice is the pharmacy is also in control of dispensing the medicine and can really ensure that patient in a rural part of the state is going to get their hands on the actual medicine. Because too often than not, even a person having a telemedicine visit and then they're left on their own to get their PrEP medicine, that's a area another point where a person can fall off.
Tisha, how about you out in Spokane area?
Yeah, I think for a lot of folks, and we're probably not much different, I think COVID really did expand telemedicine for a lot of people. We were sort of toying with it before COVID, just with that, because we have the Idaho population that we serve as well, and getting them care was becoming kind of a difficult thing. And so we started with the population there getting telehealth even before COVID, but it really has opened up, I think, care for a lot of patients, especially our younger population who their schedules just do not work with a 9 to 5 or 8 to 6 clinic. And so they are much better at making it into those telehealth visits. And if they'll no-show us 7, 8 times, then all of a sudden we get them a telehealth visit and they're very consistent, and they'll get their labs and they'll do everything that we need. And so I do think it's definitely an area that could probably be expanded upon and improve probably some of those things that we're lacking with suppression rates, just offering more availability and ways to get their care.
And it sounds like the Kelley-Ross experience has been really with that younger population where, some of the data was showing that that's sort of the a difficult population to be able to reach. I know there's a number of questions in the chat. I'm not going to get to all of them in our remaining 3 minutes. Karen, you mentioned sort of the Ryan White enrollment, and some may not be familiar with that. I think where there's some concerns about continued federal funding. Do we have a solution, past that, or anything that we should be, being proactive about?
I think Beth probably would have more information on that regards.
Yeah, thanks, Karen. So yeah, we do hold the Ryan White Part B grant and work with our partners in the Part A, Ryan White Part A, which is the Seattle King County area. I have thrown my crystal ball out of my window. I will tell you this, the loss of federal funds for any of our work will have a devastating effect. I mean, that's just, there's no easy way for any other way for me to say that. To date, we have not lost any of our federal funds. I still have existing contracts and agreements with the Health Resources and Services Administration for our Part B program. It is a partial award because we're in a continuing resolution, as all of you know, but that we've been there before, so that's not an unusual circumstance. Our HIV prevention funds come from CDC, which I think saying that they're in turmoil is the nicest way I can say that. I am awaiting funding from them, and no indication for this fiscal year that I'm not going to get that. There is a lot of leaked press. I have not seen that play out in reality yet. But the last thing I'll say about this is we also have a state budget deficit. And I'm waiting on a state budget from the legislature and the governor's office, which should be hopefully coming soon. And they also, those state allocation dollars that come into this office in the Department of Health fund a significant amount of our prevention programming that includes syringe service programs, PrEP-DAP, and community-based organizations. So it's kind of across the board right now. We are all concerned about funding.
Well, I know we're right up at the top of the hour. I want to thank all of you for your participation and all the folks that came in and listened. We'll answer some of the other questions that came out. I know there's some questions about pharmacy billing. We'll try to put links in there, in our response to you, and try to get as much of this tied up as possible. I think another topic, I heard was, boy, we need to start talking about syphilis, but, maybe that's a talk for another time. But thank you all very much. Have a great rest of your day.
Thank you.
Thank you.
Thank you.